Do you have, in your approach to treating advanced chronic GVHD, patient phenotypes or a specific algorithm that makes you decide one agent over the next?
Yeah, great question. In terms of phenotypes, not so much. You saw the data with the agents shown there, and the organ responses are by and large comparable. It's very hard to say one organ responds better than another. The caveat being there was a lot of excitement about belumosudil in patients with lung GVHD, and I'm very hopeful that we'll see a signal there in the trial that you lead. And so in patients with lung GVHD, I will say that I typically go to belumosudil early in that population. There's also encouraging data with axatilimab, and we saw data from Dr. Sereda looking at ruxolitinib. So even there, it's hard to say. If a patient had a B-cell malignancy, of course, you may think about ibrutinib in that population. Ruxolitinib has pretty much been studied more earlier on, so at least my algorithm is typically to go to ruxolitinib as next line therapy after steroids. I often do use sirolimus, and if the patient doesn't have an adequate response after 3 months or they progress before then, I go to belumosudil, and because generally it's easier to give an oral agent than an IV before going to axatilimab. It would be reasonable to do axatilimab as well. That would be my general approach.
Yep.